Yeah, it basically refers to the CheckMate 040 trial. In the past, where several cohorts had been assessed, amongst them was ipilimumab, and that was investigated in a 3-arm design with different doses, and the most effective dosing regime was in the end taken over to be analyzed here now in a frontline therapeutic assessment. The CheckMate 040 data were sufficient for FDA to grant accelerated approval for second line, and now we have the first line data. Yeah, so it's the first interim analysis, which was planned, which is, however, actually quite mature. So the median follow-up time is almost 3 years. And what we saw was indeed a statistically significant and clinically meaningful improvement of overall survival. The control arm, which in fact was basically lenvatinib, 85% lenvatinib, 15% sorafenib, investigators were allowed to choose. So that arm was 20.6 months, also very long, but the treatment arm ipilimumab reached 23.7 at a hazard ratio of 0.79. This is highly statistically significant. And what is very interesting, as we have observed it in other immune oncological interventions, the tail of the curve is very stable. The landmark analysis at 2 years and at 3 years shows a great difference. At 3 years, 38% of the patients are alive in the treatment arm compared to 24%. So that is a major improvement. And that's in addition supported by a very high rate of objective response, 36%. This is in fact the highest objective response rate which has been published in a phase 3 trial in unresectable hepatocellular carcinoma so far. And those who respond, they respond for a very long period of time, more than 30 months. Primary endpoint overall survival, that was positive. The secondary endpoint, that was objective response, positive. Duration of response, 30 months. And also an assessment of quality of life. And there is indeed a delay, which is statistically significant. There's a 24% reduction with respect of the deterioration of symptoms related to hepatocellular carcinoma. So it comes along with an improved quality of life. Yeah. It's very consistent with what we saw. So this trial comes with some toxicity, so there were some fatalities. 12 patients died in the treatment arm, and because of treatment-related adverse event, that was for the most part hepatitis. That's something we know. There was a requirement for corticosteroid intervention in about 29% of the patients. So there is some tox, but that happens relatively early. It's typically well manageable, and for the long-term run, and we saw that also by the quality of life data, after week 29 they are, after a small initial decline, they were improving again after 29 months. So nothing unexpected with respect to toxicity, but the regime, just to recall that, up to 4 CTLA-4 interventions were allowed, IP up to 4 times. That adds some toxicity, no doubt, compared to monotherapeutic interventions. I believe that the data are sufficient to support approval of this combination. So we have, besides Iron-Brave 150, Himalaya, now a third active combination, which is very beneficial for our patient. In the end, we are not treating tumors, we are treating patients, and we have more to offer. There are certain aspects we are still lacking. That is, for example, the prediction of response. We would need predictive biomarkers, particularly as we have more different options, how to choose. That is one of the things which is complex. And you can predict, I mean, we saw monotherapy not sufficient, doublets work. Now we go for triplets.